We can now talk about the cholinomimetic agents. I have a question to start this topic off. What effect do cholinomimetic agents have on the cholinergic outflow? Well, cholinomimetic agents all act to increase cholinergic outflow. The name cholinomimetic means it mimics the action of acetylcholine, which is going to stimulate the cholinergic receptors. So here's another question for you. What do meiosis, diarrhea, sweating, urination, bronchospasm, and lacrimation all have in common? Well, they're all signs of increased parasympathetic nervous system activity. So increased parasympathetic nervous system. Sweating is actually a sympathetic response, but unlike most sympathetic responses, it's going to be mediated by acetylcholine, so it can be caused by cholinomimetic agents. So an easy way to think of this class of drugs is they're going to cause people to ooze from every orifice. That is, they're going to increase secretions and also cause this wet picture. All right. Well, since it causes a wet picture, why not turn this class into a blue ocean? So that's why I have the blue background here. I just wanted you to think of cholinomimetic agents. I want you to think of this blue wet picture. So with this in mind, it'll be easier to remember that they can exacerbate certain conditions like COPD, asthma, or ulcers because you increase secretions of the respiratory mucus or the gastric acid. So there are two major classes of cholinomimetic agents, both the direct agonists and the indirect agonists. So how do the cholinomimetic agents work? We'll first start off with our direct agonists. So bethanechol, carbachol, pilocarpine, and methacholine are all going to be direct agonists. In other words, they're going to actually directly stimulate that muscarinic receptor. So they're going to directly stimulate the muscarinic receptor. So let's bring them in one by one here. So bethanechol. Bethanechol is going to be used for postoperative and neurogenic ileus and also urinary retention because it's going to activate the smooth muscle in your bowel and bladder. A useful mnemonic, or a way to remember this, is going to be, Bethany, call me if you want to activate your bowels and bladder. So our second drug is going to be carbachol. It's primarily used for glaucoma and works by stimulating the pupillary contraction, and that actually relieves your intraocular pressure. So you can remember this drug as a carbon copy of acetylcholine. So if you're trying to remember what its action is, just remember it's a carbon copy of acetylcholine. The methacholine is used as a diagnostic test for asthma. It's going to stimulate muscarinic receptors in the airway when it is inhaled, and the patients with asthma will become hypersensitive, leading to an exacerbation of their asthma conditions. Remember, the M in methacholine stimulates muscarinic receptors. And don't forget that asthma can be diagnosed by a methacholine challenge test. And our fourth drug, which is a direct agonist, is going to be pilocarpine. Pilocarpine is a potent stimulator of sweat, tears, and saliva. It's going to be resistant to acetylcholinesterase, giving it a long half-life. Helpful mnemonic to remember pilocarpine is you cry, drool, and sweat on your pillow. So you have a wet picture on your pillow. So we just covered 4 direct cholinomimetic agents. Now let's talk about the indirect agonists. So the indirect agonists are going to be a second class of cholinomimetic agents that work by not directly stimulating the muscarinic receptors. Well, if they don't directly stimulate those muscarinic receptors, how do they work? So they're going to act as cholinomimetics by inhibiting an enzyme, and that enzyme is going to be acetylcholinesterase. So these agents are actually going to be acetylcholinesterase inhibitors. Now, how does that work? Well, acetylcholinesterase is going to be an enzyme found in the synapse of cholinergic neurons. So as soon as acetylcholine gets released, this enzyme starts to break it down. And if you inhibit that enzyme, if you inhibit breaking down the acetylcholine will last longer in the synapse, and therefore you're going to increase endogenous levels of the acetylcholine. So let's go ahead and start off. We're going to throw in three drugs: donepezil, galantamine, and rivastigmine. Now these are used to treat Alzheimer's disease, and they've been shown to improve cognition and behavior. So these drugs are believed to be helpful in Alzheimer's disease because they combat the reduction in acetylcholine levels caused by the death of those cholinergic neurons in the brain. It's important to note that these drugs only transiently improve the symptoms, but do not actually alter the course of the disease progression. You're not actually bringing those neurons back to life, you're only replacing some of the acetylcholine that's lost by the death of those cholinergic neurons. Our second drug that we can talk about is going to be edrophonium. Now this is an extremely short-acting acetylcholinesterase inhibitor, and it's used in the diagnosis of myasthenia gravis. By flooding the receptors with acetylcholine, edrophonium would now temporarily relieve the effects of myasthenia gravis. So now that we have more complex anti-acetylcholine receptor antibodies, we're going to use those to actually diagnose, but it's helpful to learn about the concept of edrophonium because it may show up on boards. Neostigmine. This is an indirect acetylcholine agonist that's used primarily for post-op and neurogenic ileus and urinary retention, long-term treatment of myasthenia gravis, and also the reversal of post-op neuromuscular junction blockade. So it's a quaternary amine, meaning it is permanently charged and does not penetrate the central nervous system. So to remember this, just think about how neo and no sounds alike, so there's no CNS involvement. Physostigmine is used in the case of an atropine overdose. It's a drug that's going to be able to cross the blood-brain barrier, so it can penetrate to the central nervous system. An easy way to remember this is that physostigmine fixes atropine overdose. And then lastly, we can fill in our last part of the table here with pyridostigmine. It's going to be used for long-term treatment of myasthenia gravis. Now, it also is a quaternary amine, meaning it does not penetrate the central nervous system, just like neostigmine. It also increases muscle strength because of the increased acetylcholine in the periphery. So with all cholinomimetic agents, be careful for the exacerbation of COPD, asthma, and peptic ulcers when giving to a susceptible patient. Well, why is this? It's because these drugs act on the M3 receptor, the muscarinic 3 receptor, and cause bronchoconstriction and also increased gastric acid release. So make sure the comorbidities will be tolerated with these agents when given. Suppose we have a patient who presents with complaints of difficulty getting out of chairs and problems climbing stairs. Also, her husband has noticed that her left eyelid has been drooping over the past couple weeks when she comes home from work. So when she comes to your office, you also notice that her left eyelid is drooping. You inject some edrophonium and the drooping improves. So what's your diagnosis for this patient? Well, this patient presents with muscle weakness and ptosis, classic symptoms of myasthenia gravis. These symptoms usually present later on in the day, and improvement of symptoms with edrophonium is usually diagnostic for this condition. So why do her symptoms improve with the edrophonium injection? Well, to answer this, we need to think about the disease. So here's our neuron, here is our receptor, so the square is going to be our receptor. Myasthenia gravis is characterized by circulating antibodies. So here's some antibodies that will be circulating in the bloodstream. Let's see if I can draw one upside down. So these antibodies are going to attack the postsynaptic neuromuscular junction receptor and induce receptor downregulation over time. Edrophonium is going to be an acetylcholinesterase inhibitor, meaning we're going to have more acetylcholine left in the junction. So, by increasing the availability of acetylcholine in the synapse space with the edrophonium, we're going to enhance the ability of this endogenous acetylcholine to outcompete the circulating antibodies with binding these acetylcholine receptors, thus allowing her muscles to function better temporarily. Now, if the symptoms improve, she most likely has myasthenia gravis. And as you can see here in this picture, myasthenia gravis can present with a droopy eyelid or ptosis. This is because there are few spare nicotinic acetylcholine receptors in the eyelid muscles compared to elsewhere in the body. So a reduction in the number of these nicotinic receptors by antibodies initially is going to manifest in the eyelid, because this is where you have the fewest receptors, and these antibodies are going to compete with the acetylcholine most there first, causing an eye droop. Let's move on to the topic of cholinesterase inhibitor poisoning. Notice again how the slide is blue. Remember, we've already discussed the breakdown of acetylcholine. Remember, we had our neuron, we have our synapse here with this receptor of some sort, and we've got acetylcholinesterase in this synapse. So our acetylcholine will get released into the synapse where it can act on this receptor, but it can also get broken down by the enzyme acetylcholinesterase. Acetylcholinesterase inhibitor poisoning occurs when a person ingests or absorbs too much of an acetylcholinesterase inhibitor, which effectively causes an overdose of acetylcholine. If you knock out this enzyme, there will be plenty of acetylcholine left in the synapse. So what happens when there's too much acetylcholine? Well, this is going to produce some of your typical symptoms of oozing out of every orifice, such as diarrhea and abdominal cramping. It's going to cause urination, meiosis, bronchospasm, bradycardia, excitation of skeletal muscle, CNS as well, lacrimation, sweating, and salivation. So these symptoms can be remembered using the mnemonic dumbbells. So, as you can see, dumbbells. Remember from earlier that sweating is going to be unique in that it occurs via acetylcholine-mediated sympathetic activity. However, the rest of these are typically associated with parasympathetic activity. So this is the one outlier. Cholinesterase inhibitor poisoning is also due to organophosphates, because parathion and malathion, which are irreversible acetylcholinesterase inhibitors. Because organophosphates have been used as ingredients in insecticides, the USMLE has often asked this question in the context of farmers. A patient comes to your office with complaints of excess sweating, urination, bradycardia, lacrimation, and difficulty breathing. He states that yesterday he had sprayed his field for insects. Which enzyme is the most likely inhibited by the insecticide and is causing this patient's problem? Well, we've kind of already discussed it. I'll give you a few more seconds to think it over. But if you thought acetylcholinesterase would be the best answer, you'd be correct. Acetylcholinesterase is the enzyme that is going to be affected by the insecticide. So acetylcholine normally gets released from the nerve terminal, which is going to mediate its effect on a receptor and some postsynaptic neuron. And eventually it's going to be degraded by the enzyme acetylcholinesterase. Now, in the question above, the USMLE loves to test your understanding of this subject and how it may present clinically. Farmers may use organophosphates, which act to inhibit the enzyme acetylcholinesterase. This prevents the degradation of the neurotransmitter acetylcholine, which is going to increase the acetylcholine in the cleft, which causes that wet picture, or the dumbbells picture. So now that brings up a really good question of, how would you treat this farmer that comes in with acetylcholinesterase inhibitor poisoning? Well, to treat acetylcholinesterase inhibitor poisoning, you would need to administer atropine, a muscarinic antagonist, plus pralidoxime, which is a chemical antagonist used to regenerate our acetylcholinesterase. So pralidoxime is going to regenerate our acetylcholinesterase, while our atropine is going to be a blocker at the muscarinic receptor. So here we have pralidoxime, which is going to take an inactive form of acetylcholinesterase, and it's going to regenerate it into its active form, pretty much. The caveat with pralidoxime, though, is that it must be used within hours after the poisoning. So if too much time passes, the inactivation of acetylcholinesterase will actually become permanent by a process termed as aging, and this pralidoxime will then no longer be affected if it's not given in the first couple hours.